coming up to give and brief about the kidney health, which is very important for the health of the children. So this kidney, why we have celebrated the World Kidney Day, we know that it's been the like 2 decades now for the commitment to the kidney health, with a renewed focus on early detection of the kidney disease in children. So IAP has given an initiative to bridge the knowledge gap to the better kidney care. So we have the theme as Are Your Kidneys Okay? Detect Early and Protect. So before starting, I would like to ask our president, Jivilan Chari sir, to give his remarks for this webinar.
Thank you, Dr. Suchitra. Good evening, everybody, the distinguished members of the Academy. On the eve of World Kidney Day, I welcome you all to this webinar. The theme being, Are Your Kidneys Okay? Detect Early, Protect Kidney Health. The slogan being, Be Aware, Be Alert, Protect Your Kidneys and Yourself. In this regard, I welcome our eminent faculty, Professor Dr. Manisha Sahai and Dr. Shruti Balla, expert nephrologist from Hyderabad. Dr. Manisha is a professor and head of the department, nephrology department, Usmania General Hospital. And Dr. Shruti is heading the nephrology department in Rainbow Children's Hospital. I presume both of them will take us for a cool dip into the pool of learning ecstasy regarding kidney health, primary and secondary prevention. And without wasting much time, now I invite Professor Dr. Manisha Sahai to take up with her session. Your statement.
Thank you, sir. Thank you for the opening remarks. And we will quickly move on to the first speaker today. We have Dr. Manisha Sahai, ma'am. So, Dr. Manisha Sahai, she is a professor and head of the Department of Nephrology, Usmania Medical College and General Hospital. And her academic and research, we can see that she has 13 gold medals to her credit and 250 publications, 1,500 plus guest lectures she has given. And it is our pleasure to have her here today with us to share her views. And as a national president for women in nephrology, and also she serves as an associate editor for Indian Journal of Nephrology, emeritus editor, Indian Journal of Transplantation. And internationally also she has many commitments, like she chairs the CME committee, International Society of Nephrology, KDIGO Anemia Working Under Group, executive member for South Asia Regional Board, International Society of Nephrology, and fellow Royal College of Physicians. Also, she's a committee member for that, and council member, International Society of Nephrology, chair of South Asia Regional Board, International Society of Nephrology. And it is a pleasure to have her here to share the theme for this year. That is, Are Your Kidneys Okay? Detect Early and Protect Your Kidneys. Over to Manisha Sahai, ma'am. We welcome you. Please go ahead.
Yeah, am I audible?
Yes, ma'am. Yes, you are audible. Please go ahead.
So thank you for inviting me here. It's my privilege and honor. So my topic is, Are Your Kidneys Okay? That was the theme for World Kidney Day. We all know that the World Kidney Day was celebrated yesterday on 13th March. So actually World Kidney Day is celebrated on the second Thursday of every March. It's not a fixed date. Second Thursday of every March. And this is important because awareness about kidney diseases is very limited. In fact, we had a World Kidney Day earlier in 2016, which was devoted to pediatric CKD, because most of the renal diseases have their origins in childhood. So you can remember that pediatric CKD is very, very important. And unfortunately, we do not pay much attention to it. With heavy load of communicable diseases in our country, and hospitals are overloaded with those, the non-communicable diseases take a backseat. But it's high time that now we should learn about these, because pediatric care is improving and super specialization in pediatrics is improving as well. Children are definitely not small adults, and therefore pediatric CKD is a complete field on its own. So why kidney diseases in children are important? I'm sure all of you working in private government see a lot of kidney diseases in children: AKI, nephrotic syndrome, nephritic syndrome, tubular disorders, renal vascular disease. And if untreated, undiagnosed, all of them they end up in chronic kidney disease, which is a permanent sort of a renal dysfunction, and it spoils the life for the child and for the family. So this is the thing what we are worried about, the chronic kidney disease. Now we have a huge population of pediatric CKD. Global population, we have 2 billion children, and we have 2 million children, more than 2 million children with CKD around the world. Indian data is not clearly there. In the hospital, how many have CKD? In adults, we say 10% have CKD, whereas in children, it's said around somewhere 1% of children have CKD, but this may be an underrepresentation because many of the CKD children are not diagnosed. The CKD prevalence is similar as childhood cancers. So it's one of the commonest non-communicable diseases in children. Now, why is this pediatric CKD important? Because we all know that it progresses to ESKD if untreated. Such children need dialysis or transplant, and this is a huge economic burden, either for the government or for the patient's family. Government provides free dialysis, but again, somebody is paying, our country is paying, the taxpayers are paying. And if we come to transplants, they are costly, and donors are also limited. And number of transplants in India is pretty low. It's around 15,000 per year. In India, we need around 2 lakh transplants per year. So this is overall number of transplants. Pediatric transplants, as per published literature, is roughly around less than 500. So very less transplants in our country. So that's why CKD is important, that we should prevent the patients from progressing to end-stage kidney disease. That is point number one. The second one is, most of the pediatric CKDs are at a very high risk of cardiovascular disease. You'll be surprised to know, according to one paper, children with CKD are 1,000 times as prone to cardiovascular disease. And this is because of uremic toxins, high PTH levels, phosphorus levels, which cause vascular calcification. The electrolyte disturbances may cause arrhythmias, cardiomyopathy, coronary artery disease, peripheral vascular disease. So all types of cardiac diseases are common, and cardiovascular morbidity and mortality is high in such children. The third important reason why we should be aware of CKD and try to prevent it is poor quality of life of such children. School life is disrupted. They have poor growth. Almost 30% of them have complete growth failure. And again, once they grow up, they have infertility issues as well. The other fourth important reason that we should have awareness about CKD is, most of the times it's detected late. 40% of patients who come to the pediatric nephro OPs, for instance, ROP, they are already in late stage, by which time we cannot do anything to prevent CKD. We have to end up doing dialysis or transplant, whereas we could have prevented the CKD from going to ESKD if we had diagnosed it early. That's why awareness about pediatric CKD is important. And the fifth reason why we should be aware is, now we have drugs which can retard the progression of pediatric CKD. All is not lost if a child is diagnosed with CKD. You can use nephroprotective strategies, but the point is that they are effective only if you start them early. So with this background, why it is important to know about it? We all know that chronic kidney disease is defined as kidney impairment of equal to or more than 3 months. So anything less than 3 months, we don't use the term CKD. And you can have CKD with a normal creatinine where the GFR is more than 60. And you can have a CKD with creatinine which is abnormal, high, with a GFR less than 60. So if you have GFR less than 60 and creatinine is high, it's very easy to diagnose CKD. The problem comes when the creatinine is normal, the GFR is more than 60. Here you have to look for other abnormalities in urine, for example, hematuria, proteinuria, small kidney size on ultrasound, so on and so forth. So the purpose of this slide is to tell you that CKD means kidney impairment lasting for more than 3 months. Anything less than that, if it recovers, can come as AKI or RPRF. For CKD, you should have that 3 months period. And the other thing is that you can have CKD with a normal creatinine also. If the creatinine is normal, do not forget to look for urine. So that's important. Otherwise, you'll miss the CKD. Now, this was for older children. Adults, it's fine. But again, in children, there is another problem. When does a child get to the normal GFR? By what age? This is an MCQ question also. So children generally go to the adult GFR by 2 years. So definition of CKD is challenging in very small pediatric population. You have to look at the age-specific GFRs to identify CKD. Newborn GFR is less than 60. By 5 days, it doubles. So at birth, it may be around 20. By 5th day, it comes around 40. By 4 weeks, it goes to around 60. And by 2 years, it reaches the adult GFR. So this is important to remember. So it's very difficult to diagnose CKD in children if you just apply the adult GFR criteria. But 2 years, you can use the adult GFR criteria. So this much you should remember. At birth, it's asked frequently, what's the GFR? 20. By 5 days, it's around 40. And by 1 month, it's around roughly around 60. So remember these. And then once we have identified the CKD, we should try to stage it. So staging depends on the GFR. More than 90 GFR is G1 stage, whereas less than 15 GFR is last stage, stage 5. And these stages are further divided by the presence of proteinuria. So less than 30 milligram albumin or less than 150 milligram protein per day is A1. Between 30 to 300 milligram albumin is A2, and more than 300 is A3. So this looks confusing. Many of the times, none of the pediatric prescriptions we receive mention the GFR, but make it a habit to mention the GFR and the staging of GFR. So we have understood what is the definition of CKD, kidney impairment more than 3 months with or without high creatinine. We also understood what is the staging. So we have to write what is the GFR stage and what is the protein stage. What are the common causes of CKD? So remember, the 3 main common causes are CACT, congenital abnormality of kidney and urinary tract. You must be seeing reflux children, neurogenic bladder children. They are the common causes. The second important cause is glomerulonephritis. Most important one is FSGS. Third important cause is hypertension. The other causes can be hemolytic uremic syndrome, cystic diseases, so on and so forth. But please remember the 3 important causes of CKD and ESRD, CACT, glomerulonephritis, and hypertension. Fine. So we have understood the causes, we have understood the definition and staging. So why it is so difficult to diagnose CKD? What are the symptoms of CKD? So we are all familiar with the traditional symptoms of advanced CKD. There is decrease in urine output. The child comes with swelling. And unfortunately, in India, that is the stage when we are identifying the children, when there is already swelling or the urine output has stopped. The problem is early CKD diagnosis, because early CKD can be practically asymptomatic. The children may be absolutely normal. Stage 1, stage 2, nothing will be there. So it's very difficult to pick up these stages, and therefore screening is important for children to find out these early stages. The other problem is even stage 3 and stage 4 may come with non-renal symptoms. The urine may be normal, there may not be any swelling, but child may come with anemia, which is resistant to iron, resistant to blood transfusions. So always when anemia is there, please check the creatinine, GFR. It's important. The other thing is fractures or bone deformities or rickets. Always check for creatinine because the vitamin D activation occurs in the kidney. Hypertension in young, we all know, can be of renal origin. And if the child is generally not doing well, failure to thrive, vomiting, loss of appetite, please check for CKD. So pediatricians are quite aware, and I'm happy that we get referrals when the child has been checked with creatinine whenever these symptoms are there. But again, keep that in mind. Any child not doing well, think it may be a renal problem. So that means that should we check all children for CKD? Whosoever is coming to OP in Nilofer or any hospital, Rainbow Hospital, should we check them all? So even in America, all children are not checked. In India, we do not have guidelines for universal screening for everyone because it's not cost effective. Then whom should we check? Who are the children who are at risk? So high-risk children are some children with these diseases, which are like in adults. So children with hypertension, diabetes, those who are on nephrotoxic drugs, painkillers, long-term, children with SLE, HIV children, those who are obese. This is becoming an important risk factor nowadays, and those who have a family history. So these factors are common to adults. We screen the adults for same risk factors, children also. So remember all these children, whenever they come to your clinic, please keep in mind that you have to screen for CKD. Then there are other additional risk factors in children, different from the adults. Failure to thrive, recurrent urinary infection, voiding dysfunction, abnormally looking urine, and microscopic hematuria. So these are some of the indications when you need to screen these children. Then neonates, it is again very important because this group we are totally missing. You have neonatal ICUs now, you have pediatric ICUs now. Neonatal ICUs are full of patients having AKI. Almost ICU patients, neonates, 1/3 of them have AKI. So these children are at risk for future CKD. Preterms are at risk 5 times CKD is more common in preterms. Even term infants with low birth weight also are at risk. Those with HIE, those, as I said, who have neonatal AKI, almost 30% progress to CKD. That's a huge number. Those who have received ECMO therapy, those who have undergone surgery for cardiac disease, and those with antenatally detected abnormalities. So these are the groups of children where you need to screen for CKD. So I have told you about the factors which are similar to adults. The others where children who are not doing well are neonates. This group we are missing. So go back, think neonates you are seeing day in and day out at the time of discharge from ICU. Are you advising them any sort of screening for CKD? We are not. This is one point which needs to be taken care of. That's important. So what should be the protocol? So there has been a sort of a protocol given. Just, it looks complex, but nothing to worry. What it says is, it is divided into 3 categories: preterm infants, critically ill infants with AKI, and infants with cardiac disease. So I told you they are all at high risk. So what does this timetable show is, you have to screen them at the time of discharge, 6 months, 12 months, and 2 years. That's it. So remember that. It's no need to go into details of everything, but what this chart says is, at the time of discharge, counsel the family, call them back at least at 6 months, 12 months, and 2 years. That's important. The other important thing is, once abnormality is found, you have to screen them once in a year. You have to test them once in a year. And you also have to do other tests, relevant tests. So today we are talking about screening. So we'll talk about the tests which we do for screening. The other important window period when you need to screen is during puberty. Because remember that there is a high degree of CKD progression. GFR declines 10 times faster in puberty. It is a stress to the kidney. So these are the time frames when you should investigate. So neonates at the time of discharge, 6 months, 12 months, 2 years. Then if everything is okay, you screen them yearly. If nothing is okay, then you call them frequently. At the time of puberty, again, you have to screen them. Now, fine, we have identified how frequently to screen them. What are the high-risk groups? Now, what is the toolkit for screening? In adults, we know GFR and urine albumin creatinine ratio. Is it the same in children? No. In children, we don't do a urine albumin creatinine ratio. Urine protein creatinine ratio is required in children. Normally, it is less than 0.2. We look at creatinine and we calculate the GFR. So these are the screening tests in children. Screening does not include ultrasound, all other high-end tests. They are done only if the screening tests are abnormal. So today we are talking about screening. And if screening is normal, the child continues with the pediatrician. If screening something comes abnormal, you have to refer to the nephrologist. So let us talk about these tests. Urine protein creatinine ratio, remember, it's preferred over urine albumin creatinine ratio as compared to adults. Adults, we go for UACR, children UPCR. Because normal range of UACR is not validated in children, and mild elevations may be found in children in the UACR, and there is no paper showing that UACR is superior to UPCR. So remember one thing, UPCR, that's one screening test, non-invasive. What about creatinine? So creatinine is still used, but again, it's not reliable in the first 22 hours of life. It's altered by maternal factors as well. But having said that, that's the most common, practical, cheap test available. So please do it. Now, what is different in adults and children? In adults, we do cystatin C only rarely. But in children, nowadays, the guidelines say that because of these fallacies in creatinine, cystatin C may be a better marker, especially in the first month of life, especially in preterm infants, very low birth weight infants, and any value more than 2 milligram per DL suggests AKI or an impaired GFR. If lasting for more than 3 months, it suggests CKD. So this is important, that cystatin C has become very important as per the latest guidelines in the pediatric population. Now, what about GFR? So this is again, GFR means everybody makes a face and thinks it's so complicated to calculate. But remember, you have smartphones. You can download this eGFR app. So you can see here, revised bedside Schwartz formula. Generally, that's what is used in children. In adults, we use the EPI formula. So it's important that all your prescriptions, wherever you are writing prescription for any child with high risk, which I have mentioned, your prescription should include the GFR and the UPCR. Ask yourself, put your hand on the heart. Are you doing it? We are not doing it. Please do it, because one day the child's family may sue you. That, doctor, I was at risk. These were the guidelines, and why did you not write it? So for your safety and child safety, please write the GFR and the urine protein creatinine ratio. So that's very important, and that's the crux of this talk. So once you write the protein, GFR, everything, then you do a staging. For example, if the GFR is 43 and the urine protein something 3000, the child will come to A3 category and G3B stage of GFR. So this over a period you will learn to do. This is called the heat map of CKD. We are using it regularly in adults, but in children, we are not using it very frequently, but this should be done. Now you may ask me, there are so many equations. Modified Schwartz, generally that's what you are using, but again, it's not accurate. Newborn, there is another Schwartz that can be used. CKD epi can also be used, but again, it's not validated in children. So what's the best equation? So what do you do today? Use the revised Schwartz. That's the best. I showed you in the calculator. But for pediatricians who want to know what is the best equation, this is available now. This is called CKID U25 eGFR calculator and is thought to be the most accurate of all. It requires age, sex, serum creatinine, height, and cystatin C, and it's an online calculator. So it's the most recent equation. But remember, urine protein creatinine ratio, creatinine, cystatin, and calculate the eGFR by Schwartz. If you don't have this, otherwise you can Google and check this. You will get this equation freely available as well. Other important thing in children is about microscopic hematuria. As of now, whenever we see microscopic hematuria, traditionally, what do? We look for UTI. If proteinuria is there, we refer for biopsy to the nephrologist. We look for idiopathic hypercalciuria. All that is correct. What's the new concept? Children with microscopic hematuria should be tested by genetic analysis to identify Alports. Alports is quite common, and if it is diagnosed early, you can start ACE inhibitors for renoprotection. So this is a new thing which has come for screening for microscopic hematuria and doing a genetic testing. So this is one thing which we are not doing regularly, and probably we need more studies on that, but this is being followed in the Western world. So we have talked about the screening, we have talked about the CKD, the high-risk groups. There is another equation which has come recently in children that's called a kidney failure risk equation. So now if the child's family, you have diagnosed CKD, you have given a staging of CKD, child's family asks how long my child will go into dialysis or transplant. So this equation tells you that age, sex, region, GFR, UACR, albumin, serum phosphorus, serum bicarbonate, corrected calcium. So if you put calculate, it will tell you at 5 years, what will be the risk of renal failure. At 2 years, what will be the risk of renal failure. This is commonly used in adults now, and it is validated in children as well. So remember about kidney failure risk equation. So this is what you need to know about screening. So we have talked about definition, stages, high risk groups, the protocol for screening and the screening tests. Fine, we have identified that the child is at risk. So what do we do? So among the risk factors which we have discussed in neonates, in children, some are modifiable. For example, blood pressure, sugar, obesity, those things we can modify. Some are not modifiable. Preterm infants, low birth weight, genetics, those things, puberty, we cannot modify all those things. So let us work on what we can modify. Diet can be modified. So they are called 8 golden rules. So the message of this World Kidney Day is 8 golden rules to protect your kidneys. So diet, water intake, weight, physical activity, smoking exposure, BP and sugar control, avoid painkillers, and get the kidneys tested by whatever mechanism I have shown just now. So remember the 8 golden rules. Now coming to them one by one, I'm just putting one slide for each. So there are some myths about the diet. CKD means everything is stopped. Non-veg is stopped, fruits are stopped, vegetables are stopped. That is wrong. Child with CKD can have a practically normal diet, energy as per age, no protein restriction. That's the latest guideline now also. Plant protein is better, breast milk is good, whey protein is better, animal protein, even fish, eggs, chicken can be taken. The phosphorus and potassium in plant proteins are not absorbed. So they do not cause hyperkalemia, hyperphosphatemia. Plant proteins can easily be taken. Even chicken, eggs are also okay. Fish is also okay. And in case there is high phosphorus, phosphate binders can be used. All fruits and vegetables are allowed. In advanced CKD, maybe we can restrict banana and citrus fruits, juices, but otherwise in early stages, all are allowed. Vitamin D, as you give for a normal child, the only thing which needs to be supplemented is vitamin D. All other vitamins, no supplementation, just like for a normal child you give for CKD. Minerals also as per the normal child. Electrolyte supplements need to be given for tubular disorders. The only important thing is avoid junk food, fast food, because they are the foods which contain a lot of potassium and phosphorus, which is easily absorbed, and they contain a lot of sodium as well. So practically normal diet for CKD early stages. like you give for normal children. No restriction of protein or energy. That's what the take-home message is, 2024 guideline. Salt, tell the child to take less salt, but that's not enough because they'll go for Lona salt. Lona salt contains high potassium. So you have to specifically tell them, don't go for rock salt, Lona salt, use less salad dressings. We tell them to use vegetables, they use salad with lot of dressing. The salad dressing contains sodium. Avoid pickles, papers. So there is no point in restricting salt and having pickles, papar, everything. Lemon can be used instead of salt. And read food labels. So these are important. Kali mirchi, zira, cinnamon, those things are better rather than using salt. Then the other important thing was about the smoke exposure. So generally, smoking is not very common in our children. But second-hand smoke exposure also is important. So this is important to counsel the parents that is a risk factor for progression. Then this exercise, nowadays the focus is on both aerobic as well as the resistant training, 3 days this, 3 days that. So both are important. Another important thing is, like, many of the children join gym and take a very high protein diet, and we are getting cases where adolescents are coming with rise in creatinine. So too much of protein, 1 gram per kg per day or 0.8 gram per kg per day is fine, but not huge amounts of protein, because that's become a fad now, and we are getting renal failure because of very high protein intake in gym goers. Then water, this we neglect. So dehydration is one of the important causes of AKI and progressing to CKD. That's called heat stress nephropathy. So 6 to 8 glasses of water per day. Ideal body weight. So this is very important. 20% of children all over the world have become obese. So stick to normal body weight. What about blood pressure? Target in CKD is less than or equal to 50th centile. That's the target. And the drug of choice for maintaining the blood pressure is ACE inhibitor or RAS blockade. Any of them can be used, especially in CKD. That's a drug of choice. Don't be scared of hyperkalemia. That doesn't occur till the last stages of CKD. And RAS blockade is mandatory in your prescription. Don't be scared of it. Use proper doses. If you have a child with CKD and your prescription doesn't have a RAS, you will be again liable to be sued in a consumer protection court. So please ensure that it's there. ESCAPE trial is landmark trial, which shows they are very protective. RAS, either ACE or ARB, any of them can be used, but remember to use proper doses. Then glycemic control, HbA1c 6.5 is what is recommended. So we have talked about those golden rules. Now some new concept has come about some drugs which can cause renoprotection. So what are these drugs? Till now, in adults, we were using these drugs, but in children, there was therapeutic nihilism. We were not even bothered about pediatric CKD. We were not even testing these drugs. First drug is SGLT2 inhibitor. It's very uncommonly used in children. Many of the pediatricians won't even have heard of it. But now it's being discussed. SGLT2, they are for diabetes, but we use them for renoprotection. So you may ask, SGLT2, they cause sugar loss in urine, they reduce diabetes. How they are renoprotective? They are renoprotective because they reduce hyperfiltration. Kidney becomes damaged because of more and more work, hyperfiltration. So what happens is when some part of a kidney is damaged, the remaining part hyperfilters more and more, and this causes more renal damage. So what do SGLT2 inhibitors do? So in CKD, what happens is most of the glucose and sodium is absorbed in the proximal tubule. There is hyperfiltration, absorption more and more. This pump is active, that SGLT2 is hyperactive in CKD. So most of the sodium and glucose is absorbed in the proximal tubule. So there is less sodium to the distal tubule. The macula densa feels that it's not getting sodium. So it tells the afferent arteriole, I'm not getting sodium, give me more sodium, more hyperfiltration. So there is vasodilatation, there is increased glomerular pressure and increased hyperfiltration. And this leads to CKD and progression of renal damage. Now, when you use these drugs, SGLT2 inhibitors, as the name shows, what do? They block this. They block this, which is overactive in CKD. So now what happens to the sodium and glucose? Everything goes to the distal tubule. Distal tubule is satisfied because it's getting more sodium, more water. So it tells the afferent arteriole not to send further fluid. There is, again, afferent arteriolar constriction, which is the main mechanism of action of SGLT2, reduce glomerular pressure and decrease filtration. So these are very, very important drugs. They are not only anti-diabetic, but they reduce the weight, reduce blood pressure, cardioprotective, smart diuretics, reduce albuminuria, reduce renal work. So they are very good drugs. And in adults, it's mandatory to use these drugs for all CKD. Now look at this statement. If these drugs are started at a GFR of 85, almost normal GFR, they retard the CKD for 26 years. So patient can be without dialysis for 26 years. And if you start them late till 20 GFR, again, you get 2 years of dialysis-free life. So this was in adults. Now there are trials in children, which you should be aware of. Dapagliflozin in children with inherited proteinuric renal diseases. So dapagliflozin is being tried in Alports. We have a double protect trial. That's the name of the trial which is going on. So soon SGLT2 will be used for retardation of pediatric CKD. Fine. So DAPA would be started. Then what else? The other important drug in adults is GLP-1RA. This is again an anti-diabetic drug and it's become the standard of care. But again, in children, do we use it for nephroprotection? No, as of now, there are no studies. We are using liraglutide for obesity only in children, but this drug can be used in children and trials are going on for nephroprotection. So as of now in our prescription, this we are not adding. As of now, we are not adding DAPA, but in a year's time, the trials will be completed and these drugs would flood the market in pediatric sector also. Then third important nephroprotective drug is finerenone. It is again used in adults for diabetic CKD adults generally when they have persistent proteinuria and a low eGFR. The only side effect is hyperkalemia. What about children? Children with CKD. So you have a Fiona trial in children with CKD and proteinuria where this is another nephroprotective agent. So you have three options, DAPA, GLP-1 and finerenone, which are soon going to come in pediatric market for CKD protection. Any other therapy which we are using now? Yes, we can give bicarb supplements. If the bicarb in children is less than 80, this retards the progression of CKD, correct the anemia. We have iron, we are having erythropoietin, and we have desidustat as well, which is a new drug, oral erythropoietin. Then treat the mineral bone disease parameters, calcium, phosphate, vitamin D, maintain normal levels. Growth hormone can be given. What about statins? In adults, we use statins for almost all CKDs, diabetic CKDs, non-diabetic CKDs. But in children, as of now, they're not recommended by KDIGO. But American guidelines have started recommending statins for CV risk reduction in children more than 10 years. And atorvastatin is generally the statin of choice. And vaccination. So these parts we can do in present day era also till we are waiting for all these three drugs. Specific treatment, what is available as of now is for glomerulonephritis, we give steroids. For genetic, we give RAS blockers and SGLT2 will come soon. For genetic diseases such as polycystic, we have Vaptans. For some other diseases, glomerular diseases, we give immunosuppression. So specific treatment can be given when required. So the meaning of this slide is, apart from the general therapy for CKD, which is very important, the 8 golden rules, the nephroprotection, then this is the third segment, that is specific treatment, if we are able to identify the cause of CKD. As the child is growing older, there should be transition of care and not a transfer of care. So the pediatricians and the adult nephrologists should work in close collaboration. We should not just dump the child in the adult nephro unit. Adult nephrologists are not very comfortable dealing with children. So it should be a gradual transition. It should be a strong relationship between the adult and pediatric nephro groups. What's the way forward? Who should take care of these CKD patients? Who should do the screening and all that? Should the pediatricians be doing it or should the pediatric nephrologists be doing it? Remember, we are 1.4 billion Indians. Total number of nephrologists in India, both pediatric and adult included, is 2,500 only for 1.4 billion. Pediatric nephrologist number is even more limited. And early stages of CKD in children are seen either by adult physicians or by general practitioners or maybe by pediatricians. Even at some centers, there are no doctors, nurses see these patients. So who should be taking care? All these groups should be trained in taking care of CKD, and what they should be trained in, just recognizing the high-risk groups and doing urine protein and the GFR. That's it. That's the whole message. If anything abnormal, send it to the nephrologist. It should be done at primary care, secondary level, and in tertiary care. And the screening packages should be included in Arogyashri or Ayushman. Because we have a dialysis package, we have a transplant package. We are spending so much. Dialysis package is 20,000 per month. Transplant package is 3 lakh to 5 lakh package. We are spending so much. Government is providing free treatment, I understand. But what we are missing is we are not preventing the CKD. We are only arranging for CKD when it's gone to end-stage kidney disease. Nation is losing so much of money. So screening packages should be there. Cost of screening is only 500 and cost of treatment is only 3,000 per month as compared to huge cost in dialysis and transplant. And the way forward again is what you should do. Government should include those packages, but what you should do is every prescription of yours in high-risk children, UPCR and GFR should be mentioned. And you should check all the golden rules, the 8 golden rules, whether you have 1, 2, 3, 4, 5 listed them in your prescription. Just writing BP medicine is not enough. Diet, vaccination, everything should be there. So concluding, this is our department. This is our dialysis unit. We do 3,000 dialysis per month, out of which around 700 dialysis are for pediatric CKD patients. We are not happy about it. This shows that we are failing in controlling the pediatric CKD. We have done around 800 transplants so far. 12 have been pediatric transplants, multi-organ transplants, and both living and deceased donor transplants. Total number is around 800. Pediatric transplants are also all doing well. This is one of the pediatric transplants. He had glomerular disease. You can see his steroid face, he's short stature, but now he is doing very well. He is running his own hotel business. Transplant was done free of cost for him. Mother was the donor. This is a pediatric transplant recipient transplanted at the age of 13 years when I was doing my post-graduation in nephrology. And now he is a software professional, married, and he is the father of 2 kids. So you can see the man in the picture is pediatric transplant recipient at 13 years of age. This is the first pediatric deceased donor transplant in our hospital. This was a child simultaneous pancreas kidney transplant for type 1 diabetes. So do you think we are happy with the numbers of dialysis and transplant? We were happy at one time, but now we have realized a good doctor only does dialysis. A better doctor may do transplant also, but the best doctor is the one who prevents the patient's progression to either dialysis or transplant. So that is the theme of World Kidney Day, prevention. And you can do prevention if you screen and detect early. And that's why the message, are your kidneys okay? You people are all working, trying to do best in your field. We are trying to do best in our field, but we are working alone. We are not collaborating. So we need to collaborate. Together, I think we can make a difference. Thank you very much for a patient hearing. I'll be happy to take if there are any questions.
Thank you very much, ma'am. That was a wonderful, lucid presentation. And you have taken us through a journey all the way from how the kidneys are getting affected and how we have to see in pediatrics how the chronic kidney disease sets in and what are the preterm indications, term babies, and who are the ones affected, how to calculate the GFR. Then you have told us to the drugs that we are supposed to use, especially when you said about the dapagliflozin. This is a new one for obesity. Yes, definitely the food related issues, the obesity related issues, everything that has fallen in place and CKD well presented. And I think if somebody has missed today, that they will definitely take it up from the YouTube. And it was a very good talk, ma'am. And I can invite few questions from any of the audience. If you want, please raise your hand so that we can take a question. If no questions are there, then we will move on to the next topic. And Manisha ma'am, we thank you so much, ma'am, for a very short notice. You have come forward to give us and deliver such a wonderful lecture. And we always look forward for the renal transplants, what you have mentioned, Jeevan Dan, also you're part of it. And Usmania is doing a very excellent job in doing this free of cost. So I encourage everyone, whoever comes across this, to please go ahead with registering of the cases at the earliest and refer the CKDs at the earliest so that it becomes easy for them not to reach to the level of dialysis or transplant. So we'll move on to the next topic.
Thank you. Only thing, my message, parting message to everyone is risk groups. Keep in mind every child coming to OP and do a urine test and a GFR. That's it, and write it on the prescription. Thank you very much.
Thank you, ma'am. Thank you very much. So we will move on to the next topic. We have Dr. Shruti Balla here with us, who will be sharing with us about the recent updates of the hypertension. So Shruti Balla, she is a pediatric nephrologist. She is from Rainbow Children's Hospital. She has been done her fellowship from Medanta Hospital and presently practicing at Rainbow Hospital, Tirmalgiri. So over to Dr. Shruti Balla.
Good evening, everybody. Thank you for inviting me to this webinar, and it's a pleasure to be here. Without wasting much time, let me take to you through the recent updates of UTI in children. As till now, Madam has told us how important is early detection and prevention of kidney disease in childhood. UTI we most commonly see in children, which is the most common bacterial infection, and especially those children who are associated with vesico-ureteric reflex or obstructive uropathy, leads to kidney scarring and long-term renal damage. So, uh, just because it is a simple UTI, it should not be left alone. So, I just wanted to discuss all the recent updates of UTI in children. And all these are recent Indian Society of Pediatric Nephrology guidelines, which have been updated based on the evidence. So, ma'am, am I audible?
Yeah, yes, madam. You are audible, madam. Please. Yes.
So, coming to the definition, it is the proliferation of bacteria in the urinary tract. Sorry. Give me a second, please. Okay, so the definition, there is presence of proliferating bacteria in the urinary tract, which causes tissue invasion and inflammation. Why is it very important? Because it is the most common bacterial infection in children, and 30 to 40% of children with the first UTI usually have underlying urinary tract anomalies. So early diagnosis and treatment are critical, especially to prevent renal scarring. And the risk of recurrence is very high, particularly in infants and young children. Around it is like 10 to 30%. So how do we classify UTI? It is based on four things which we have to keep in mind. One is level of complexity, whether it is complicated, uncomplicated. The second one is based on the site of infection, whether it is upper tract or the lower tract. The type of infection, it is acute or chronic, and the symptoms, whether he is asymptomatic or symptomatic. And we should know what is a relapse and reinfection, because the same bacteria can cause recurrence of infection within 2 weeks of treatment. That is, there might be persistence of the bacteria, so that can cause relapse. Reinfection is infection with a different organism after treating it fully. So how do we differentiate whether it is an upper tract or a lower tract? Upper tract usually seen in children less than 2 years of age, with they have very high temperature. The lower urinary tract symptoms would not be so much, but the CRP would be raised with increased creatinine, ultrasound changes, or photopenic areas on the DMSA. While the lower urinary tract usually uh, uh, comes with for more than 2 years with normal CRP, and usually there will be lower urinary tract symptoms like the voiding dysfunction, and they present with suprapubic pain. So age-wise, what is the clinical presentation? Uh, Usually in the neonates, they present with fever, jaundice, vomiting, irritability, and very poor feeding. There will be non-specific signs. In infants and toddlers, there will be fever, lethargy, abdominal pain, foul smelling, urine. In older children, it is easy to detect because they can complain us regarding dysuria, urgency, frequency, flank pain, as well as fever. So, how does this 2023 ISBN guidelines differ from the previously revised guidelines? The first ISBN guidelines were given in 2001. Later, the revision happened in 2011, and now in 2023, the guidelines have been evidence-based and released. So, how are they different? They are different in diagnosis because they have given emphasis on urine dipstick with leukocyte esterase and nitrate screening. imaging after the first episode. Initially, it was very aggressive approach. Now it is less aggressive, which I would be discussing in further treatment. Then treatment prompt antibiotic therapy, and they have discussed on duration. Prevention, especially limited antibiotic prophylaxis and shorter duration of antibiotic prophylaxis. And primary VUR, they have mentioned when only surgical is required, and most of it is conservative. So how do you diagnose? The diagnosis is based on single growth of uropathogen, significant colony count, and presence of symptoms, while urine culture is considered as gold standard. So what are the collection methods? The preferred is a clean catch in toilet trained children, while alternative in non-toilet trained children also the first would be clean catch. But if it is not possible, then catheterization or suprapubic aspiration. But suprapubic aspiration is not commonly done. Alternative is catheterized sample. Always avoid bag collected urine because it has high risk of contamination, especially 30 to 80% with the adhesive bags, and it is 64 with the nappy pads, and this has not to be used for any urine culture collection. So urine analysis as a screening tool, as I said, the diagnosis, they have sorry for the inconvenience. So urine analysis as a screening tool, the leukocyte esterase and nitrate tests, they have been utilized in the OPD practice now. This picture represents that just a color coding system on the urinary sample as a bedside test helps in detecting the UTI because they have a good specificity and the sensitivity rate. Freshly void microscoping might also not be required if the dipstick is available. So they have been emphasized on the importance of these dipsticks in the pediatric OPD practice. While if it is a microscopy sample, then more than 10 WBC per hyperfield field suggests the UTI in an uncentrifuged sample, and in a centrifuge sample, if it is more than 5 WBC. The sensitivity and specificity of microscopy, we know it is 90 and 76%. So what is the basis of this leukocyte esterase and nitrate test? So leukocyte esterase usually detects the enzyme which is released by the neutrophils in response to infection. So any positive test suggests pyuria or a possible UTI. It can, but the differentiation is difficult because it can be positive in sterile pyuria also, and false positives can occur in vaginal contamination. And nitrite test is specific more than this leukocyte esterase because it detects the nitrites which are especially produced by the gram-negative bacteria. They convert these urinary nitrites into nitrates. So any positive test suggests there is some gram-negative bacteria in the urinary tract, and it supports the diagnosis of UTI. So based on this leukocyte esterase positivity and nitrate, how do we interpret? So if both are positive, then we have to send urine for culture and treat it as UTI starting antibiotics. But only nitrate is positive, still send urine for culture and start antibiotics if it is a freshly voided sample where you have tested for the nitrate. If leukocyte alone is positive, then you send it for microscopy and culture, and based on the symptoms and only if you have a good evidence of UTI, then you start antibiotics. If both are negative, it is not UTI, explore other causes of fever, but still you have to send for a microscopy if any other underlying structural abnormalities of the kidney are present. But this dipstick interpretation in infants is usually limited because they tend to void frequently. The incubation period for bacteria is short in the bladder, and the nitrate concentration is not adequately achieved. So it should be interpreted in caution. So if in the microscopy, once we see that the bacteria is present, then yes, usually it is more than 5, which we see in the report. So you treat it as UTI and send it for culture. If the bacteriuria is negative, then only based on the symptoms you decide whether it is clinically indicated or not. So what are the criteria from the urine culture for diagnosis? This has been changed. Initially, even a single organism from suprapubic aspirate used to be considered positive for UTI, but now this has been changed to more than 10 power 3 coliforming units per ml. And in a catheterized sample, it is more than 10 power 4. And in a clean cat sample, initially it was 10 power 5, but now this has been reduced to 10 to the power of 4 to 5 in symptomatic infants, because many pooled studies analyzed and suggested that if we are strict with 10 to the power of 5 in symptomatic infants, we are especially missing few UTIs. So once we detect a child with fever with no focus and in the presence of risk factors and urinary symptoms, you perform a dipstick and send urine for culture. As I said, if Li or nitrite is positive, start empirical antibiotics, and then based on the culture, we decide whether we are continuing or not. If both are negative, then assess for underlying risk factors. Risk factors here are structural kidney disorders. If it is there, then you send for culture, and then depending upon the culture, you decide how long to give. If nothing is available, then wait for culture. If it is negative, no need to start antibiotics. So what about the treatment? As they said, prompt antibiotic therapy. That means it is preferably within 48 to 72 hours within the onset of fever. So what is the drug of choice? In children, it is third generation cephalosporins or a simple amoxicillin clavulanic acid. In adolescents, it is first generation cephalosporin like cephalexin or cefadroxil or amoxicillin clavulanic acid. So which route is preferred? Oral route is preferred in all non-toxic infants, and IV route is preferred if the infant is less than 2 months of age, severely ill patients, and who are not able to ingest the oral antibiotic. So now this is the thing which has been changed. Initially, the duration of therapy according to the 2011 guidelines used to 10 to 14 days for cystitis and pyelonephritis also. Now this has been reduced to 3 to 7 days in cystitis, and in pyelonephritis it is 7 to 10 days. If a child is non-toxic, then even in pyelonephritis, oral antibiotics can be considered. And there is emphasis that there is no need to repeat a urine culture after successful treatment. How do you know that it is successful treatment? You have to monitor for symptoms. Antibiotics should not be used for treatment of asymptomatic bacteria, and repeat urine culture should never be performed in an asymptomatic child. So what is the basis for this? Because study pooled analysis has shown that there is no difference in kidney scarring at 12 months and recurrent UTI between oral and intravenous antibiotics followed by oral administration. And also initial antibiotic therapy has to be changed only if there is clinical treatment failure regardless of antibiotic sensitivity. This has to be kept in mind. And guidelines also say that clinical response is crucial while assessing the effectiveness of antibiotic therapy, and this has to be assessed within 48 to 72 hours of starting the antibiotic. So once you diagnose, you define whether it is an upper tract or a lower tract. So if it is a lower tract, as I said, in cystitis, now it is oral antibiotics for 3 to 7 days instead of 10 to 14 days. If it is a febrile UTI with pyelonephritis, then look for risk factors. If there's less than 2 months or sepsis with other things, then yes, you give IV antibiotic for initial 3 to 4 days, and then you change to oral depending upon the culture sensitivity. So when do you call it as asymptomatic bacteriuria? If the urine culture is positive, but in the absence of symptoms. What did the studies say? Why treatment is not required in asymptomatic? Because these have very few virulence factors compared to the normal uropathogenic species. And also long-term studies in children have shown that it has caused no difference in the decline of glomerular filtration rate or kidney growth, even in untreated children. So, but the only condition where you consider treating asymptomatic bacteria in children is who are undergoing any instrumentation of the urinary tract. So how do you monitor and follow up? Always look for symptom resolution. It should be expected within 48 to 72 hours. But if it is persisting, all the symptoms beyond 48 to 72 hours, you have to reevaluate, look for other causes. And follow-up culture, as I said, only if clinically indicated, do not repeat it. And response to therapy is based on resolution of symptoms. Look for all the symptoms with the child presented and look for the symptom resolution within 48 to 72 hours. So what are the indications for imaging after a first episode of UTI? Ultrasound, yes, all the guidelines say all the children with first episode of UTI, you should do an ultrasound either during the episode of UTI or just finishing treating it. MCOG, initially it used to be done for all children, but now it is reserved for children where there is high suspicion of VUR. So it is indicated if there is recurrent UTI or if there is any abnormal ultrasound in the sense there is hydronephrosis or any ureteric dilatation, cystitis, and in non-E. coli UTI in children less than 2 years of age. So please remember, MCUG not for all, it is only reserved if there is recurrent UTI, abnormal ultrasound, and non-E. coli UTI in less than 2 years of age. DMSA scan only if there is recurrent UTI and high grade reflux, that is grade 4 and grade 5 on the MCUG scan. So what is the goal of imaging? Why imaging is important? Because it will identify those with underlying structural kidney abnormalities, especially obstructive uropathies, which require surgical intervention, and any other risk factors which are predisposing them to increased risk of UTI, and to identify those chronic changes if there is any parenchymal damage which predisposes further to kidney scarring and later on CKD. So kidney bladder ultrasound, why is it the first investigation? First thing is it is non-invasive and it gives information on the basic structures, that is the kidney size, shape, bladder configuration, the ureters, the dilatation and all. As I've shown in the figure, this is the focus which we do. Usually first we look for the kidney shape, size, the corticomedullary differentiation, then you look for the PCS dilatation, then you look for the bladder and rest of the other things. Tones or any dilatations can be easily identified on the basic ultrasound. Micturating hysterurethography, as I told you, it is considered in 3 conditions and it gives information mainly on the bladder lesions, the urethral lesions, the competence of the VUJ and posterior urethral valves in boys, and it also helps in grading of the VUR. As you can see, and when is this MCUG scan performed? Usually MCUG scan is performed initially when you treat the UTI within 2 to 3 weeks of completing it and not beyond that. And it should always be done under prophylactic antibiotic because it can have a risk of developing UTI. And once it is done, then yes, reflux is graded according to the International Reflux Society. And usually grade 1, grade 2, grade 3 reflux, there is chance for subsiding if we put them on prophylaxis. Grade 4, grade 5, depending upon the condition of the child and functional status of the kidney, might require surgical correction. So when do you consider DMSA scan? DMSA scan, the recent guidelines say it should not be an early DMSA, it should be a very late DMSA, that is 4 to 6 months after treating the first episode of UTI. DMSA scan, what does it tell us? It tells us about established scar if it is done beyond 3 months. If you're suppose a child presents with acute pyelonephritis and you want to know that there is some abscess formation in the acute stage, yes, DMSA is done. But in case of non-pyelonephritic thing, it is done 4 to 6 months after the presentation of UTI. And the most important thing is it tells us also the differential function of both the kidneys. So the recent guidelines say no to acute phase DMSA because it has very poor specificity in detecting high-grade VUR. It cannot identify permanent kidney scars, cost, and variability in interpretation also. The guideline emphasizes late phase DMSA, that is 4 to 6 months after the presentation and treatment of UTI. So what are the risk factors for scarring in children? Delay in instituting antibiotic therapy, prolonged duration of fever, the number of febrile episodes the child is having, and presence of high-grade VUR, and multiple focal scars on the DMSA. How do the scars look on DMSA? Usually there is irregular renal contour with diminished tracer uptake. So you're having a child with first episode of UTI, and if there are other risk factors like non-E. coli UTI or recurrent UTI, you are first doing an ultrasound. Then once the ultrasound, then you confirm to do whether this MCUG is required or not based on the recurrence and all. If MCUG is abnormal, yes, then you have to go for DMSA and look for scarring. That DMSA is usually done 4 to 6 months after the first episode of UTI. So what is the role of antibiotic prophylaxis in prevention of UTI? Why is it important? Because 30% may experience recurrence. Why? Because there might be bowel bladder dysfunction and primary VUR. These two have been given much importance in the recent guidelines, which I'll be talking now. Then 10 to 15% with acute pyelonephritis have risk of developing kidney scarring. And initially in 2011, ISBN guidelines recommended prophylaxis in all children with primary VUR. Now it has been changed to limited prophylaxis. And why they have changed to limited prophylaxis and shorter duration? Because they found that the risk of antibiotic resistance with prophylaxis is 3-fold higher in this population. And the major thing is outcome of scarring is not affected by antibiotic prophylaxis. Nearly 21 pooled studies have done, and they have told that renal scarring has not been affected by continuous antibiotic prophylaxis. So what is the role? It is not recommended in a normal urinary tract in the absence of bowel bladder dysfunction, and children detected to have antenatal hydronephrosis while awaiting evaluation, including MCU. Initially, the guidelines stated that any child with antenatal hydronephrosis put on prophylaxis till the imaging is done. Now this has been changed. Awaiting imaging in antenatal hydronephrosis, role of antibiotic prophylaxis is not recommended. And it is indicated if there is high grade VUR, grade 3 to 5, and recurrent febrile UTI in patients with underlying bowel bladder dysfunction and infants with low grade VUR. So what is the drug of choice? In more than 3 months old children, it is cotrimoxazole or nitrofurantoin. Between cotrimoxazole and nitrofurantoin works better, but the oral tolerability is bad with nitrofurantoin. So cotrimoxazole is most commonly used, and the other antibiotic which can be used is cephalexin. So once you start, when and in whom you consider to discontinue it, there are only two. One is toilet-trained children without underlying bowel bladder dysfunction, and if there is no febrile UTI or breakthrough UTI in the preceding 1 year in a child who is on prophylaxis. Circumcision, do you consider? Yes, it should be considered for prevention of UTI in case of high-grade VUR and in presence of recurrent UTI. So this is a summary according to the ISPN guidelines. As I said, urine dipstick in the OPD practice, send for culture, look for nitrate positive, negative, then assess for risk factors. Then once it is confirmed, start on antibiotics, then assess for bowel bladder dysfunction, do an ultrasound in all MCUG depending upon the recurrence and risk factors. And if there is anything abnormal in the MCUG, go for late phase TMSA scan. So what is this bowel bladder dysfunction? You can see the picture depicts everything here. So it is a lower urinary tract symptom spectrum, which is accompanied by constipation. Its prevalence in UTI patients is around 41%, and those who have underlying UR, it is 49%, quite high. So how do you assess for this bowel bladder dysfunction? Ask if there is any incontinence, holding urine maneuvers, voiding postponement, urgency, postures, and especially elicit history of constipation. What do you see in an ultrasound which tells you that yes, there is underlying bowel bladder dysfunction? Look for post-void residual volume, anything beyond 20 ml in 4 to 6 years, 10 ml in 7 to 12 years, and thickened bladder wall, more than 5 for full bladder or 3 mm. Usually say that there is underlying bowel bladder dysfunction. This is just a screening history, and the following features have to be correlated. Do you have to consider any uroflowmetry in these children? Yes, uroflowmetry has to be considered once your training involvement has not been achieved or the constipation has not been treated properly. You have to go for uroflowmetry also. So what is this treatment for bowel bladder dysfunction? Now these recent guidelines emphasize urotherapy. What is this urotherapy? Urotherapy is nothing but maintaining a dairy. As you can see here, we should tell them like what is his intake, how many times did he pass, how many accidents did he have in the morning, whether he's feeling a urinary leak, he has urgency and all. Based on these, we can decide whether he's having this bowel bladder dysfunction or not. We usually ask him to date for a week or so, this diary. This is very important. Apart from that, we have to ask him to increase the fluid intake and reduce the intake of caffeine and chocolate because these trigger constipation. And yes, frequent and double voiding. These has to be emphasized because every 2 hours, and what is double voiding? Once the child comes, once he passes urine, then make him be in the same position, ask him to count 1 to 10, void again, then ask him to count 1 to 10 and void again so that he doesn't have any residue left behind. So frequent double voiding has to be emphasized. So adequate posture, yes, posture is also important, especially in girls. Then for bowel, yes, hydration, fiber intake, and polyethylene glycol. And this polyethylene glycol, it has to be given, and it's not for a like say 1 month or 2 months. It has to be given until the stool consistency has been achieved. So when do you consider referring to a pediatric nephrologist? If there is recurrent febrile UTI and there is abnormal ultrasound, persistent proteinuria or hypertension, or having high-grade VUR or breakthrough UTI on a prophylaxis. What are the red flags when you should suspect? If there is renal growth failure, hypertension, on prophylaxis, multiple episodes of recurrent breakthrough UTI, or when you're evaluating for screening where you see proteinuria, hematuria, and an elevated creatinine. So UTI in special populations, yes, neonates, it presents like sepsis, so IV antibiotics are required. And as Madam has already emphasized, once there is UTI in neonates, yes, they have to be followed until they are 1 year of age. If there is underlying neurogenic bladder, yes, CIC with prophylaxis has to be continued. Renal transplant patients also, yes, UTI is common and early detection is very crucial to preserve the graft function. So the take-home message, these new guidelines are applicable globally for the management of UTI and VUR. Urine culture is considered significant, and in the clinical suspicion is strong, you should immediately start antibiotics. As I said, leukocyte esterase and nitrate are used as alternative screening tests to normal routine urine microscopy. In pyelonephritis, it can be treated with oral antibiotic in a non-toxic infant for 7 to 10 days. MCUG is indicated if there is recurrent UTI, abnormal ultrasound, and non-E. coli UTI in children less than 2 years of age. DMSA, as I said, only late phase who have recurrent UTI and high grade. And prophylaxis, yes, it has to be given in children, especially having this bowel bladder dysfunction and with those high grade VUR. And once the prophylaxis is started, it should be stopped in a toilet trained child who doesn't have this underlying bowel bladder dysfunction and there is no UTI in the last 1 year on prophylaxis. And as I said, antibiotic prophylaxis is not indicated in children with normal urinary tract and also children awaiting imaging with an antenatally detected hydronephrosis. In case of high-grade VUR, surgical intervention is considered only if there is parental preference or there is recurrent breakthrough UTI on antibiotics. Thank you. So any questions?
Yeah, it was a very wonderful presentation from you, Shruti. And we have one question from Tilak, sir.
Yes.
Causes for foul-smelling urine and how to interpret. That's what sir has posed a question to you.
So usually these children with foul-smelling urine, yes, most of them when we screen them, they usually present with cystitis. So you get an ultrasound, look for bowel bladder, underlying bowel bladder dysfunction, and yes, you have to treat them as UTI if there is cystitis, and even if the urine culture is negative.
So thank you very much, Shruti, for giving your wonderful presentation within a short period of time that we have given you. Thank you so much. And over to Srikanth for the vote of thanks for this session. Yeah, and if all of you can just keep your screens on, all the participants, if you can keep your screens on, we can take a picture. So this will be carried for the IAP presentation. Thank you. Srikanth.
Yeah, thank you, madam. At the outset, I wish everybody a happy Holi, although the day has completed. Thank you, Dr. Manisha ma'am, Professor and HOD of Nephrology Department of Nephrology, Usmania Medical College, for joining us and giving enlightening on the to detect early and screen to detect and to protect our kidneys of the child, for enlightening us and taking us through a very enlightening talk. Thank you very much, madam, for joining. And I also thank Dr. Shruti Balla, madam, for making us know the recent changes in the guidelines of management of UTI. Thank you very much. And I thank all the participants, especially our president, sir, and all the EB members and all the pediatricians of Twin Cities. Thank you very much. Thank you, Suchitra, madam.
Thank you all for your patient listening to this session. So we will call it. And I thank and acknowledge presence of Tilak sir also. Tilak sir is editor-chief for the journal. And this time I take to tell you all that if you have any articles to be published in the Twin Cities, you are always welcome to please share it in the mail that has been circulated in your groups. Please check your mail so that we have sent for the editor board. Thank you.